Picture this. You went to your doctor. You said you couldn't sleep. Your anxiety was through the roof and you kept gaining weight no matter what you ate. Your brain felt like it was running in slow motion, and then your doctor told you it's stress or depression, or maybe they even ran a thyroid panel. But guess what? Nearly 40% of women seeking care for perimenopause symptoms have been misdiagnosed. The most common diagnoses: anxiety, depression, even ADHD. And this keeps happening because only 31% of OBGYN residency programs include any dedicated menopause education. But get this, I'm not here to criticize the educational system and maybe what the curricula are missing, because ultimately I want to help you solve this problem. And today I'm here to fix what the curriculum may have missed. Perimenopause isn't just a hormonal inconvenience. It's a decade-long biological transition that shapes your brain, your heart, your bones, and your muscles. And what you do during this window matters more than most women are ever told. So is this you? Well, let's break down what's actually happening. Quick foundation here. Menopause is a single day, the day you've gone 12 consecutive months without a period. The average age in the US is 51. Perimenopause is the transition leading up to it. And that can start on average somewhere around 46, but for some women, it's happening in their late 30s, and it may extend out 4 to 8 years. Pretty long duration. What's happening during that time is anything but a smooth decline. Estrogen spikes and crashes in a very unpredictable way. And that volatility is what drives a lot of these symptoms: hot flashes, night sweats, sleep disruption, brain fog, mood swings, weight gain around the midsection, joint pain, heart palpitations. And the reason I think it gets misdiagnosed as potentially anxiety or thyroid disease is that the symptom lists overlap almost completely. Here's the thing that changes from a symptom conversation to a longevity conversation. Estrogen has receptors in virtually every organ: your heart, your brain, your bones, your blood vessels. And when production becomes erratic and then eventually just drops off altogether, the downstream effects affect all systems at once. This is why perimenopause is being recognized as a biological inflection point, not just a life stage to survive. Let's unpack this further and talk first about your brain. See, 2/3 of all Alzheimer's cases are in women. And for a long time, the explanation was that women live longer. But the research now points to something more specific. In fact, a 2025 review confirmed that estrogen is directly neuroprotective. It supports brain cell metabolism, it reduces neuroinflammation, and it protects brain blood vessels. When estrogen drops at the point of menopause, neuroinflammation actually increases. That subtle underlying inflammatory process may actually begin Alzheimer's pathology years before symptoms appear. A meta-analysis of over 50 studies found that women who started hormone therapy within 5 years of menopause had a 20 to 32% lower risk of developing Alzheimer's. Women who waited until 65 or later saw a 38% higher risk. Now, I want to be very precise here. This doesn't mean every woman should use HRT. Much more importantly, using HRT to prevent Alzheimer's, there is no clear scientific baseline or guidance that I can provide here. But what it does tell us is that timing matters. The brain has a window of estrogen sensitivity. Start support during that window, and you may actually preserve these protective effects. Let that window close, and you can't reopen it. But I'm going to come back to HRT in further depth here in just a minute. Let's shift gears now and talk about your muscle and bone, because estrogen also protects muscle and bone. And when it drops, both deteriorate faster. And the data on how much faster is something most women are never shown. Sarcopenia, which is age-related muscle loss, is actually more prevalent in women than men. Muscle loss accelerates in the perimenopausal through the postmenopausal period. This matters for longevity because muscle is your metabolic engine. Low muscle mass drives insulin resistance, metabolic dysfunction, and increased risk of falling. Grip strength alone is an independent predictor of bone mineral density in postmenopausal women. They are so tightly connected, but let's break down the bone side of this conversation, because osteoporotic fractures affect 40 to 50% of women over a lifetime versus roughly 13 to 22% of men. 1 in 5 women over 60 has osteoporosis, and bone loss accelerates to roughly 2% per year in the first 6 years after menopause. But by then, a significant loss has already happened. The lever here is really resistance training. In fact, a 2025 meta-analysis confirmed it significantly improves muscle strength, gait speed, and functional capacity in older women. Weight-bearing exercise exercise is also one of the strongest stimuli for maintaining bone density. The window to build this protection is early and often. The younger you are and the more resistance training you engage in, the more muscle mass, more muscle strength you have going into perimenopause through the process of menopause. I want to address hormone replacement therapy directly because the confusion around it is still actively harming women. In 2002, there was a trial that produced headlines saying HRT in women caused breast cancer, heart attacks, and stroke. HRT use dropped from 26% of US women to under 5% almost overnight. And what's crazy is that fear has persisted for the last 2 decades. But here's what the headlines missed. The WHI enrolled women with an average age of 63, more than 12 years post-menopause. Many of those women already had early cardiovascular disease. And when researchers stratified the data by age and timing, the picture changed completely. For healthy women under 60 or within 10 years of their last period, the risk profile of most HRT formulations differs significantly from what the original study showed. A 2025 Menopause Society meeting study found women who started estrogen during perimenopause actually had approximately 60% lower odds of a heart attack, stroke, and breast cancer compared to women who never used hormones or started later. This is the timing hypothesis. HRT initiated early may actually extend out the cardioprotective effects that your own estrogen was providing. Start late and that benefit begins to disappear and risk can actually increase. For bones, the evidence is beyond solid. HRT slows early postmenopausal bone loss. And for menopausal symptoms, it remains the most effective treatment available. Nothing else even comes close. But it is important to note that this is not a blanket recommendation for every woman. There are contraindications that do exist. Formulation and route matter. Transdermal estrogen has a different risk profile than oral estrogen. This is a conversation that has to be individualized with an expert who actually knows menopause medicine, which brings me back to the training gap. 1 in 3 OBGYN residents who did get menopause training said they still wouldn't offer HRT to a symptomatic woman with no contraindications, despite the overwhelming evidence supporting the use of HRT. Here's what I would recommend for my own family member to do. Get a full hormonal workup. Estrogen, progesterone, FSH, LH, sex hormone binding globulin, testosterone, not just a thyroid stimulating hormone level. Start resistance training now, at least twice a week. Prioritize protein. Aim for anywhere from 1.8 to 2 grams per kilogram of body weight per day. And then have an honest, evidence-based conversation about HRT with a clinical provider who actually knows what they're doing. Perimenopause is not something that just happens to you. It's a decade where the decisions you make determine how you age. If this helped you, share it. Drop your questions in the comments and subscribe if you want more of this type of content because we're only just getting started on women's health and longevity. I'll see you in the next one.